Chair of panel 2 is Marie Høgh Thøgersen from Dignity. Marie is a psychologist responsible for monitoring and clinical research at Dignity. Marie will also take a point of departure for the role as moderator in her clinical work with people who have experienced solitary confinement and who have come to Dignity. So please, the floor is yours.
Thank you very much, Elna. Hello, everyone. I'm happy to help to assist you through this panel, or the second panel of the day, our health panel. We'll discuss the health consequences of solitary confinement. And I'll start by shortly presenting our panel members. And I'll start with you, Marie Brasholt. We are very happy that you could step in last minute for Jens Moderator, who is unfortunately not able to make it today. But Marie, you work very closely with Jens in the health unit, and you'll talk to us about, give us an overview of the health impacts of solitary confinement, a general overview. Following which, Ida Koch, who is a psychologist and a member of the isolation group. He'll talk to us about the Danish Experience, really drawing on the Danish research and the mental consequences and mental and physical consequences in Denmark. Yeah. And after that, we'll have you, Sharon Shalev, joining us all the way from Oxford. And you're also a fellow at the Mannheim Centre for Criminology and at the LSE, London School of Economics. You will have another perspective, talking to us about what makes solitary confinement harmful and how these harms can be mitigated. So welcome to you too. And then we have Peter Scharff Smith joining us from Oslo, from the Department of Criminology and Sociology of Law at the University of Oslo. And you're also a member of the Scandinavian solitary confinement. Yeah. So welcome. We very much also welcome a discussion on the health consequences of solitary confinement here at Dignity. In our clinic, as many of you know, we have a national clinic on the 3rd floor in this building where we see victims of violence, traumatized refugees every day, and from them we know, they tell us that what happens in prison does not stay in prison. We see this, how social deprivation, how this is something our clients deal with for a very long time. And I think it's worthwhile to mention that many of the patients we see we are referred after, on average, 14 years in Denmark. We're a highly specialized center, so it's difficult to get in here, but just to let you know that after 14 years, they're still dealing very much with the consequences. And I hope to also bring this into the discussion, how we document the long-term consequences of confinement. But I think we should start, and I'd very much like to give the floor to you, Marie.
Thank you, Marie. I think I need to stand for this. I'm very humbled to step into Jens's shoes. When he called me yesterday and told me that he wouldn't be able to come today, I got a bit busy. Fortunately, Jens has provided me with his speech, so I'll try to give that to you. Deprivation is a well-known family of torture methods, and if you, as a kind of torture, put a person into a dark room for a long time, that is, you deprive him of light, over time he will become confused and he will lose sensation of time. This highly unpleasant condition will put a pressure on him, so that he eventually might behave as the perpetrators want. The same applies if you do not give him food or drink or necessary medicines. The hunger, thirst, exacerbation of disease symptoms, and the associated weaknesses will similarly put a strong pressure on the victim. If these conditions amount to severe pain or suffering, it might amount to torture. In 2014, an experiment was made that showed that even very short-term deprivation of light, sound, and social interaction could produce psychosis-like symptoms, even with healthy participants within a period of only 25 minutes. So how about deprivation of meaningful social contact in prisons? The rationale behind using isolation as a punishment is obviously that isolation is an unpleasant condition. But does isolation also involve a risk to the health? And if it does, is it only during the isolation? Or is there also a prolonged effect? And does it affect both physical and mental health? In this presentation, I would address two issues. One being the scientific medical evidence for health impact of isolation, and the other one being what we already spoke about briefly, the role of health professionals towards prisoners in isolation. We, that is the health department in Dignity, have based the assessment of the medical evidence on a literature search undertaken by Dignity's Documentation Centre. Our very able students, Andreas and Nicoline, who are also present today, have reviewed the studies identified and selected those 12 studies with the highest relevance and the best research methodology. Approximately 35 studies from our search were excluded, mainly because of methodological flaws in design or measurement techniques. They, however, did not show results very different from the studies included. The studies considered included several study designs, including randomized control trial, only one, qualitative group interviews, also one, and the rest were longitudinal and case control studies. The settings of the studies were pre-trial detentions in prisons in Denmark, Norway, the United States, Canada, Italy, and England. The number of participants varied between 20 and an impressive 134,000 in one of the register-based longitudinal studies. All studies of the impact of isolation have to deal with the problem of selection bias. Or now that we're close to Easter, we could also talk about the chicken and the egg. What comes first, the psychological symptoms or the isolation? In other words, have those in isolation showing psychiatric disorders been put in isolation because persons with psychiatric disorders more often than others are put in isolation? We might hypothesize that it might very well be the case. We don't know much about this, but it's a plausible assumption that people with psychiatric disorders more often get involved in disciplinary offenses due to conflicts. Also misunderstandings, stigmatization, substance use, or the like. Studies including a control group will, if conducted properly, isolate the effect of the isolation itself. But our experience from the studies that we have found is that very little has been done so far. The findings in the studies were the following. Brain activity is affected by isolation. Psychiatric disorders and other health problems like sleeplessness and concentration problems were more frequent among detainees in isolation. There were dynamic developments in psychiatric disorders and function during the first few months of detention. That is, isolated detainees maintained their level of disorders while non-isolated detainees improved their situation. The risk of psychiatric hospitalization increased by time in isolation. After 4 weeks, an impressive 20 times increased risk. Some psychiatric problems seem to be reversible, and some disappear after release from isolation. However, the risk of suicide and risk of self-harm considerably increased when comparing isolated with non-isolated detainees, even when controlled for length of jail stay, age, race, and severe mental illness. So in conclusion, the findings of increased psychiatric problems among isolated detainees are likely reflecting several phenomena. One, that detainees with major psychiatric disorders are more likely to be isolated. Two, that isolated detainees develop psychiatric disorders, of which some may disappear once the isolation stops. And three, isolated detainees with latent or manifest psychiatric conditions are likely to deteriorate under isolation. The overall results of these mechanisms seem to be a considerable excess risk of suicide, which is 4 to 6 times increased compared to non-isolated detainees. As medical doctors, we have an obligation to attend to detainees and prisoners in order to treat conditions and improve their health situation. This also applies to detainees in isolation. And here I want to make a slight detour and remind you that international standard is that medical professionals should be independent from prison health authorities in order to maintain their independent assessment of the prisoners. I would also like to recall certain articles of the Mandela Rules and the European Prison Rules. They have already been briefly mentioned by Stephanie. The Mandela Rules address directly the role of healthcare personnel in disciplinary sanctions, and they say healthcare personnel shall not have any role in the imposition of disciplinary sanctions or other restrictive measures. They shall, however, pay particular attention to the health of prisoners held under any form of involuntary separation, including by visiting such prisoners on a daily basis and providing prompt medical assistance and treatment at the request of such prisoners or prison staff. Further, in rule number 46.2, healthcare personnel shall report to the prison director without delay any adverse effect of disciplinary sanctions or other respective measures on the physical or mental health of prisoners subjected to such sanctions or measures, and shall advise the director if they consider it necessary to terminate or alter them for physical or mental health reasons. And the last one from the Mandela Rules, healthcare personnel shall have the authorities to review and recommend changes to the involuntary separation of a prisoner in order to ensure that such separation does not exacerbate the medical condition or mental or physical disability of the prisoner. And actually, the European prison rules are not much different. They state that the medical practitioner or a qualified nurse reporting to such a medical practitioner shall pay particular attention to the health of prisoners held under conditions of solitary confinement, shall visit such prisoners daily, and shall provide them with prompt medical assistance and treatment at the request of such prisoners or the prison staff. And another slight detour, I want to mention that Denmark actually reserved the right to comply or not with this because of opinion that the requirement that prisoners held under solitary confinement be visited by medical staff on a daily basis raises serious ethical concerns regarding the possible role of such staff in effectively pronouncing prisoners fit for further solitary confinement. That's a direct quote from the European prison rules themselves. And finally, another provision also from the European prison rules that the medical practitioner shall report to the director when considering that a prisoner's physical or mental health is being put seriously at risk. This, as mentioned, puts the health professionals in a precarious dilemma which is sometimes referred to as a dual loyalty dilemma. Is the doctor furthering the interests of the patient as promised in the Hippocratic Oath, or is the doctor furthering the interests of the law enforcement agency, for instance ensuring that the agency may dose disciplinary measures accurately without actually causing irreversible damage to the detainees? This may be referred to as a grey zone between health and security. On the one side, as stated in the Mandela Rules, the health professionals should not get involved with the imposition of disciplinary sanctions, but rather use their professional skills to benefit their patients. Obviously, the risk is that the doctor condones measures which are actually causing a negative health impact. This would imply that the health professionals do not accept attending to isolated detainees on a daily basis, as stated in the Mandela Rules and the European Prison Rules. because doing so would implicitly mean that if a recommendation to discontinue the isolation is not done, this is accepting the continuation of the disciplinary measure. On the other hand, the rules provide the detainees with a safeguard that somebody will monitor and intervene if there are visible health consequences of the isolation. If doctors and other health staff refuse to undertake the daily monitoring, who will then look after the isolated detainees and check if their health is adversely affected? The solution is not easy. It might be argued that the law enforcement authorities themselves must take responsibility and ensure that they do not impose adverse impact on detainees or prisoners by means of disciplinary measures. This could imply that prison staff monitors the isolated detainees and call on health staff if there is any reason to do so. The disadvantage of this approach is, of course, that non-medical staff may not be fully capable of assessing the mental health situation of the detainee and may miss indicators of negative impact. In conclusion, the law enforcement agencies should eliminate this medical dilemma and not use any disciplinary measures that carry with them a risk of harming the detainees or prisoners' health. Using isolation as a punishment is jeopardizing the health and even lives of detainees and prisoners. Thank you.
Are there any short clarifying questions for Marie? We'll have a discussion following all presentations. No clarifying questions? Okay, thank you. Ida, will you take the floor, please?
Thank you very much, and thanks for this impressive conference. It's wonderful to see, as an old fighter against for the abolition of isolation, to see that this whole debate is going on and on and on, which is very necessary. And I also want to thank you for the fantastic documents you sent out before. It's very helpful for us working in the field. What I'm going to say is something which is very well known. Oh, I forgot my remote. Is banal. Maybe it's a ground for this whole discussion. I'm going to talk about the mental, social and physical consequences from a psychological point of view, as I'm a psychologist and a criminologist. I will just remind the audience of the impacts of isolation, and there will be some repetitions from former talks here. Isolation means a quite considerable, or total, but considerable reduction or deprivation of normal sensory stimuli, of normal perceptual possibilities, of normal physical exercise, movement and action. On the top of that, it means a quite considerable reduction of normal and meaningful contact and interaction with other human beings, the so-called social deprivation. This cocktail of deprivation can have those severe health effects on human beings, and by the way, on other living species, as Peter Scharff once told us a story about horses, I think. Research shows that social deprivation probably is the part of the isolation complex that has the most violent consequences on human beings. Now I go back in history because all what we know, we've known for a long, long time ago. Developmental psychology, experimental as well as clinical, has shown that normal child development depends on adequate sensory and social stimulation. It's so simple that if they don't get it, they get crazy and some of them die. Now, kids are human beings. Also, the adult personality and intellectual health, capacity and level of functioning depends on relevant and adequate sensory stimulation and social contact and stimulation. So we've known it for a long time. We have loads of knowledge about the consequences of isolation from not at least US research from the middle of the last century. A very good overview of this you can find in Peter Scharff Smith's article from 2006. It's in the bibliography. And we have a lot of recent research. The research more or less show all the same. However, we are in Denmark, and I shall here refer to research from Denmark and to other Danish contributions. After years of critique, not at least from the Danish Legal Justice Association, the isolation group, I've been a member for 2 decades working for abolition, the Danish government, or the Minister of Justice, took the initiative around 1990 to carry out a research of what they called the possible, the eventual impacts of isolation during pre-trial detention. So they questioned the whole issue. The basic report came out in 1994 and the follow-up in 1997. The former speaker just mentioned this research. The results confirmed what the international research had shown and what lawyers, prison clergymen, prison doctors and nurses had said for many, many years, and what has been documented through interviews with former isolated, interviews with relatives, letters from isolated, of which I've received a lot, from case studies, etc. Isolation is damaging and risky. The Danish research contribution showed that pre-trial detention in isolation compared to non-isolation creates stress, harm and risk of mental health disorders. 28% of isolated pre-trial detainees had medium to severe psycho after effects compared to 15% of the non-isolated. Those who had been held in isolation for more than 2 months, 43 of those got a psychiatric diagnosis. An isolated person had a 5 times higher risk to be hospitalized for psychiatric reasons after 15 days, and a 50 times bigger risk after 40 days than the non-isolated. So here you see that the time factor is very, very important. And a follow-up study showed a significant higher mortality rate among those who had been isolated. A much later study from Denmark, carried out by Benjaminsen and Eriksson in 2002, showed that the suicide rate was 12 times higher for those in isolation than those in the general population. What do the prisoners themselves experience? And this we know basically from a lot of interview studies. First, several of them feel a pressure to confess just because it's so horrible to be in isolation that they would do anything to get out, even to give false confessions. They do not recognize themselves, their reactions, their feelings, their thoughts. They get a sense of disintegration of identity. They're frightened of unaccustomed body reactions and feelings, and they do not understand what's going on with them. How should they? They've never felt this way before. They can't read, they can't watch TV, and they have problems carrying out a dialogue. And then you could say, dialogue with whom? If it's pre-trial detainees, they ever so often have a meeting with a lawyer, or they go to a police interrogation and so on. But they have problems. And they fear for their sanity with a good reason. There are various ways to categorize the consequences from isolation. I can, among others, refer to Sharon Shalev's categorization from 2008. But here I shall present Finn Jørgensen's categorization. Finn Jørgensen was a Danish psychiatrist, unfortunately dead now, and a former physician at Vestre Fængsel, the biggest Danish detention facility. He analyzed his own medical documents and all accessible material on isolation, among others the documents gathered by the isolation group. His analysis resulted in the following symptomatology, and I think it's useful. He says, isolation affects the individual's integrity and feeling of identity, the physical state, the oral, perceptual and intellectual and cognitive ability, and the social competences. He distinguished between what he called the acute and a more chronic state or symptomatology. The acute isolation syndrome, which means a cluster of different symptoms, can appear after just a few days in isolation. The syndrome includes such as problems of concentration and direct thought disturbances, restlessness, failure of memory, sleeping problems, impaired sense of time, and self-destructive impulses and behavior, as we already heard. Not only does concentration problems, thought disturbances, and memory problems make every day in the cell very monotonous, as the isolated person cannot occupy himself with reading, watching television, etc., as nothing really makes sense. It also is a severe problem, for instance, for pre-trial detainees who recurrently is taken into interrogation with the police, where they expect the prisoner to make a coherent statement, which does not vary from interrogation to interrogation. It can also destructively influence at the meetings between the prisoner and his lawyer, and now I'm talking about pre-trial detainees. The acute symptoms can turn into a more severe state when isolation is prolonged, longer than a few days, longer than a few weeks, where the acute symptoms are worsened and turned into what Jørgensen calls the chronic symptoms. Chronic because the symptoms sometimes continue long after the prisoner is out of isolation. The chronic isolation symptoms include such as inexplicable exhaustion, depression and lethargy, apathy, lack of emotional control, misbehavior and lability. And exactly this thing is important when we talk about isolation as a disciplinary measure, because some of the consequences of being isolated can be lack of emotional control and misbehavior. And when they then get out of isolation, they have this malbehavior, or what you call it, and then they, as a punishment, are turned into isolation again. A lot of them get psychosomatic symptoms, speech impediments, and hallucinations, anxiety and paranoid conceptions, and psychosis. I forgot to put that on, but that's important. Growing introversion we see, and refusing of contact. The psychosomatic symptoms might be muscle weakness, hair loss, weight loss, nausea, head and stomach aches, tics, these involuntary movements. And the lability symptoms can be like a swinging between fits of weeping, lethargy, and fits of rage. The social consequences, of course, are mainly seen and experienced after end of isolation, when there is a possibility to be together with other people, other inmates or relatives. They fear a lack of ability to cope with social control. On the one hand, they can't be alone, they cannot be behind a locked door, but then when they go into an area where there are other prisoners or people, they can't cope with being together with them. They can't carry a dialogue, and they have these speech impediments. They feel they cannot cope or manage physical contact and emotional contact, which means, of course, problems related to their relatives. Isolated prisoners might, in the first period of isolation, try to dilute the social isolation by appealing for contact, like calling the staff, asking for toilet visit ever so often, and the like. These attempts to get a minimum of contact, however, usually gets less and less numerous after some weeks, and if isolation continues, the isolated might end refusing contact at all. They can turn into a state of autism. This has been shown years and years ago from studies about maternal deprivation. Some recent research, but there are very double meanings about that, says that most symptoms are reduced when people are getting out of isolation, but I understand that there are very diverse ideas about that. So my last slide, nobody said anything about the time, or can't I see? Who is affected, how and when? And from what I have been able to dig into of material, it seems that it's not possible to predict who, when and how. We know something about children, pregnant women, mothers. Kaba, Lewis and others from a study in 2014 showed very clearly that minors, kids under 18, are more sensitive and in higher risk than the grown-ups. But what we know is that the risk is generally higher the longer a person is kept in isolation. This goes through all research. And it seems that the risk rises with each additional day in isolation. So, to conclude, human beings are social beings. It's very banal. They are hurt and harmed when they are deprived from especially social, meaningful contact. Thus, to be affected by isolation can be seen as a normal human reaction to an abnormal and harmful condition. Yes.
Thank you, Ida. Are there any clarifying questions for Ida? Short, clarifying questions. Yes?
Would it make a difference?
Sorry, if you could please, just tell us who you are.
Morten Guldman Høgh, the Department of Business Probation.
Thank you.
Would there be a difference if the person knows that this isolation is going to stop within a certain time, for instance 15 days, as a punishment, for instance, and instead of more ordinary pre-trial isolation?
This I cannot document, but I think 15 days is a very, very long time. We have already heard of that. But I think the question of time is quite important. I mean, we know from the indefinite sentences, unlimited sentences, that's very damaging because there is no counting. Time is such an important factor. So it might be important to know, well, after 3 days, you're definitely out of isolation. It wouldn't maybe not make that pressure, mental pressure. So I don't know, this is my best answer.
And one last clarifying question?
No, actually, just to add to that, I'm Stephanie again from the OSCE. Just to clarify to that, now in those minimum standard rules, the Nelson Mandela rules, when it's used as disciplinary measure, it has to be defined how much time, the duration for which offense it may be applied, and this has to be communicated to each and every prisoner when he arrives to the prison, so that this is very clear, so that there shouldn't be a lack of knowledge about the time duration when it's applied as a disciplinary measure, at least.
May I, sorry, of course, you're right there. My question was only if the known time factor is important, contra if it's not known.
My guess...
Which you answered.
My guess is yes.
Great. Thank you. I think we have to move on now. Please take the floor.
Thank you very much. Hi everyone. I'm going to have to join the congratulations again for the excellent background paper, and thanks for organizing this event. It's great. So the title of my presentation is a bit misleading, because the best way to mitigate the harms of solitary confinement is to avoid isolating people. It's not a natural state for us as social creatures. As Ida said, that's banal, but that is absolutely the case. We're not built to be isolated. We need human contact and human touch to define and maintain a very, very sense of self. We need sensory stimulation to keep our brain activity going and our emotional well-being intact. And we need to be able to exert some control over our environment and maintain a degree of personal autonomy. Solitary confinement robs the individual of these things. It is a practice which affects the human psyche in very well documented and very profound and often subtle ways. As we heard, the health effects of solitary confinement include some very, very serious symptoms, both psychological and physiological. These range from sleeplessness and problems with eyesight to anxiety, irritability, depression, hopelessness, anger, rage, panic attacks, hallucinations, and much more. We also know that some of these effects can be long-lasting and in some cases irreversible. Some effects may only manifest long after the individual's release from solitary confinement. I have spoken to prisoners who felt fine, and then suddenly something happened 2 years down the road, 3 years down the road, some event triggered, and all their experience of solitary confinement just came up, flooding them. So what I plan to do over the next 8.5 minutes or so is to try and put a human face on these very disturbing but rather dry lists of adverse health effects, of signs, symptoms and illnesses. And I'm going to try and recount what men and women who have spent some time in solitary confinement have told me about it, and asking what it tells us about what makes the pains of isolation most acute and what serves to alleviate them. A crucial factor, of course, and this is something that other speakers have mentioned and the Mandela rules hint at, is duration. The accounts of prisoners chime with this prohibition of solitary confinement lasting longer than 15 days. People told us that time weighed really, really heavily on them. One man said about his time in solitary confinement, "The longer you're here, the more you develop disorders. Being in such a small space has such an effect in decreasing your social skills. It has such a negative effect. It's isolation to the extreme." Another man told me, "It's all right for about a week. It's peaceful. But after that, it just starts messing with your head." Another woman used very similar terms. She said, "Your head just goes. There are only so many times you can speak to four walls." So, where solitary confinement is unavoidable, its duration must be kept short, no more than a few days, though we should note that for some individuals, even a few days can be too much. Like this one man who wrote to me, he was from the States. He was isolated for 8 days following an arrest on charges of drink driving. He wrote, "Please let me apologize in advance as I'm having some difficulty in maintaining a normal train of thought. I have just been released from 8 days stay in a local prison. Now that I'm home, I can't sleep and I'm in panic mode. During that time, I had hallucinations, conversations with myself, and tremendous levels of panic. The first 3 days were rough. The 4th day, I found patterns in the bricks that looked like pictures. The 5th day, the pictures appeared to move and tell stories." So for some individuals, even a very short duration is intolerable. The key damaging aspects of solitary confinement, social isolation, reduced sensory input, and increased near total control of most aspects of the isolated prisoner's daily life, occur in the context of a small, sparsely furnished, and sometimes windowless cell, where all activities, sleeping, eating, and defecating take place, day in, day out. As one man said, his biggest difficulty in solitary confinement was the small environment. You can't find your own space. Even in your own cell you feel enclosed. You're just stuck in the same place every day. The material condition of confinement are an important factor in how people experience solitary confinement. Segregation units are universally austere places, but some are worse than others. The design of units and cells, in-cell fixtures, the cleanliness of the place, these will all shape and affect the experience of prisoners. And this is something that several people commented on. One man said, "Segregation is a very dirty place. You get located to a cell and it's filthy. Hygiene is a big thing." And I think that people's hygiene deteriorates down here. As a psychologist in the room would know, this is a very good sign of someone's mental health deteriorating when they start neglecting themselves. A segregation unit officer used very similar terms. He said, "It's got to be a clean environment and it should be clean irrespective of the prisoner's behavior. That way you start off with less to argue about. Put him in a shithole and he will kick off." So conditions have to be decent, enabling individuals to maintain personal cleanliness and dignity. Segregation units do not have to be austere, and if they are austere, they do not need to be dirty and drab. As a minimum, the human rights standards discussed in the previous session, must be respected. But good units provide more: education, a good selection of books, a television, a radio, something to counter the boredom and emptiness of solitary confinement. Being confined to a small space with nothing to do is in itself a very stressful experience, particularly for those who can't read. One British man said, "I don't have a radio or a television. You don't know what's going on. I'm a 20-year-old man sitting all day looking at the wall. The regime is poor, and then they wonder why people kick off." And when the stress becomes unbearable and the kicking off, in turn, can, as another man said, it can be directed to oneself when we see self-harm and suicide attempts, or to others. "The thing with me," he said, "is that I have two ways of releasing stress: anger and self-harm. I harm myself or I harm someone else. And because I'm not mixing with anybody, I've been harming myself to such a degree that I've almost died 2 times." Now, we know, of course, that self-harm and suicide, Ida just said, are much more prevalent in solitary confinement units than they are in the general population, general prison population, where it is in turn higher than in the general population. The almost total dependence on prison staff for the provision of all the daily needs, which is also typical of solitary confinement units, must not be worse by further restrictions on the already very limited autonomy which people can exercise. For example, by limiting the number of times a prisoner can flush their toilet, or placing light cells outside the cell, as was the case in a number of segregation units which I recently visited in New Zealand. Our prisoners had 3 flushes a day, and that was it. If they wanted more, they had to ask an officer to allow them to flush the toilet once more. But I think that the single biggest factor in how people experience solitary confinement is the quality of human relationships that they are able to enjoy. One prison officer said, "What makes a good segregation? Staff-prisoner relationships. You have to get on with the prisoners, first name, before anything else. You have to build relationship and trust. You need humor to crack the ice." The importance of relationships, as the Mandela rules put it, meaning for human contact, in how people view their solitary confinement was evidenced by how segregated prison, in a study I conducted of England and Wales, described staff. So one man said, "Mr. X is funny, we have a laugh, he's fair. If he says he'll do something, he does it. He's a straight talker. If he can do something for you, he'll do it. He talks to me, he's helped me a lot." It doesn't take much, but it's something more than just contact that is utilitarian. The contrast here with the US Supermax prisons which I visited could hardly be more stark, with guards instructed specifically not to communicate with prisoners except in a purely functional way. In such an environment, there is no opportunity for meaningful relationships to be created. Writing in USA Today only last week, Johnny Perez, who is a former prisoner tent activist and who has spent 60 days in solitary confinement in Rikers Island, wrote, "The worst part of my time in solitary was not having any meaningful human contact. I was dependent on one corrections officer, the only person I ever interacted with, for all my needs. He never looked me in the eye, he never inquired about my well-being or otherwise acknowledged that there was another human being in his presence. Soon I started talking out loud to myself. I wasn't doing that because I was crazy or because I deserved to be in solitary. I needed to hear a voice. I needed to feel and be human." So, to sum up, the best way to counter the adverse health effects of solitary confinement is to avoid using it altogether. Where it is unavoidable, and provided the due process standards are followed, time in isolation must be short, no longer than a few days, and it must not be dead time. Prisoners should have access to activities and things to do. Material conditions must be decent. Isolated prisoners should not be expected, for example, to eat their meals next to an uncovered open toilet. But the key determining factor, and something which the Mandela rules, and for that matter the Istanbul Statement, which some of us in this room have helped draft, is treating people fairly and with respect for the human dignity, and countering the social isolation by engaging with them as the individual, autonomous fellow human beings that they are. Thank you.
Are there any clarifying questions?
No questions? Disappointed. Thank you.
Thank you very much. I think that we've all of us learned enough, so to speak, now about the effects of solitary confinement from my three distinguished colleagues. So I'll try to be brief, and what I'll try to do is to put all of this a bit even more into context, the historical context as it is, because as Ida mentioned, we've known about these effects for a long time, the effects of solitary confinement, and actually I think we've known about them for a rather long time, even longer than back in the 1980s, and you're well aware of this, of course, if we go back to the 19th century even. And what I'll be saying a few words about briefly is that if we look broadly on research and knowledge gathering on the effects of solitary confinement, I think that we can talk about three waves of research on knowledge gathering within this area. And the first one coincides with what we could call the rise of the modern penitentiary. The 19th century prison system, which what we could call the modern prisons, the prisons that our current prison systems are very much resting on today, so to speak. And in the 19th century, in the first half of the 19th century, prison reform was essentially, in many countries, a question of whether to adopt the Auburn model of imprisonment or the Pennsylvania model, two American prison models, both with regimes of solitary confinement. And the Pennsylvania model was the model with the strictest form of solitary confinement. It was the one which became the most popular all over Europe, and especially so in the Scandinavian countries. And this experiment, if you like, with solitary confinement began in earnest in Denmark in 1859 when Vridsløse Lille Penitentiary opened based on this Pennsylvania model. A few years after this prison had opened, 8 years later to be precise, the prison governor, Frederik Brun, he wrote an entire book about this prison system which he had been administering throughout the last 8 years. And he wrote, among other things, the following. He had reached the firm conclusion, he wrote in his book, that solitary confinement represents a significant danger to the prisoner's mental health. According to Brun, the inmates in his own prison fell into a state of total lack of energy and willpower, into a mental and physical laxity, which was either cured by means of fortifying medicine, a changed and improved diet, longer exercise spells or light work in the open air, or else developed into depression and subsequently to higher degrees of mental disorder. Actually, this conclusion was reached even earlier in the United States, where many states adopted this Pennsylvania model, and most of them, I'm glad to say, discarded it quite quickly. But to give you one example, a prison physician in the Pennsylvania model prison in New Jersey wrote in 1841, "The opinions expressed heretofore on the effects of solitary confinement are strengthened by every year's experience. The more rigidly the plan is carried out, the more the spirit of law is observed, the more its effects are visible upon the health of the convicts. A little more intercourse with each other and a little more air in the yard have the effects upon mind and body that warmth has upon the thermometer, almost every degree of indulgence showing a corresponding rise in health of the individual. If his mind begins to fail," this physician wrote about his own prison, "and he shows symptoms of derangement, another convict is put with him in his cell. This invariably restores the patient." So, in other words, meaningful social contact, if that was supplied, most prisoners would become healthy again. So it's of course a great tragedy that this was learned already in the 19th century, and in Denmark this sparked the first official inquiry into the effects of solitary confinement, the first study already in 1871, which was done by a psychiatrist. And he agreed that he looked at all the cases of insanity which had occurred at Vridsløse Lille Penitentiary. He agreed that there was no arguing this. These prisoners had definitely become insane. But the reason, he said, was not isolation. It was two things. These prisoners, he said, suffered from degeneration, which was a popular, if you like, psychiatric diagnosis at the time. They were born criminals, and that was why they became insane. And another important cause, according to the psychiatrist, was that these prisoners masturbated in their cells, and that was believed to cause insanity. So, and this may sound ironic or whatever term you want to use, it was commonly believed at the time among psychiatrists. So it wasn't until the early 20th century that the discipline of psychiatry agreed firmly that solitary confinement was in fact severely harmful. So this I would call the first wave of knowledge gathering in this area. The second wave has been briefly alluded to also by Ida, was after the Second World War. Studies, this was experimental research on sensory deprivation, perceptual deprivation, research which was very much sparked by debates about brainwashing of prisoners of war in North Korea, and interrogation methods in Eastern Europe and in Russia as well. And there was quite a large literature developed, experimental literature, which showed if you use strict sensory deprivation, you can start hallucinating even within a few hours. Actually, that was the most extreme experiments. And then the third wave of research is what I would call post-World War II, from the 70s, 80s and onwards, modern research, if you like, into the effects of solitary confinement, which includes all the studies which have been mentioned by the previous speakers. And there's no doubt we can say, based on this research, that solitary confinement has the effects which have been described clearly. But actually, even today, there are people who will dispute this, and as we speak here today, there's litigation going on in different countries, in Canada, for example, the United States, where the government has experts arguing this research is wrong. So what we're doing here is still very important. Thank you.
So, I think you have questions to each other. It's really interesting to have this update on the field from 5 different experts. So, if you in the audience have any questions or points of discussion, please report. Yes, and again, if you just state who you are, I know many of you probably know each other, but still, it's good to know who you are. Right in the back. You had a question?
Go ahead.
Oh, I have the microphone,
Okay.
so I'll go first. I'm Alice Miner, currently a research assistant here at Dignity. And my question is about taking the conversations you have about the harmfulness of isolation and applying it to a discussion about prisons more generally. Because it's clear that everyone who's presented today can agree that isolation is harmful. There's discussion about how harmful, what is harmful, how much time is important, but everyone agrees that it is harmful. And it's a two-part question. Is there a danger if focusing on isolation, is there a danger of implicitly recognizing imprisonment as a valid form of punishment? And is there a way of using conversations about the damaging effects of isolation to translate it to imprisonment generally as something damaging?
You like to
Well, that's a very good question and a very difficult one to answer, I would say. But I don't know where to start. I think apparently, if you look just at the history and the practice of solitary confinement, apparently it's almost part of the DNA of prisons. I think it's extremely difficult to find a prison system anywhere in the world where you have no solitary confinement at all, and the places where that would probably be the case is because they have huge problems with overcrowding and criminal justice systems which are very different from here. And what I'm trying to say is that I'm not sure that you can, if you want to reform solitary confinement, it's part of prison reform, so I'm not sure that you can disentangle the two issues. I don't know if that's an attempt to answer your first question, at least.
I think Ida has a comment to that as well.
I have a question to you. I heard your question and I thought, does it mean, are you thinking that focusing on isolation or solitary confinement will take away the focus from the infliction of pain when you put people in general in prison? Is that your question?
In part, yes, because I think.
Yeah, but I think you have to stand on two legs. I think you can still be an abolitionist concerning imprisonment at all, in general, and you can focus at the same time on this very extreme pain infliction, inducing pain. I mean, this Christie has been writing very good stuff about this infliction of pain.
Well, I have to agree with both Peter and Ida, but I also want to add, I get asked this quite a lot, and I've got two answers. First of all, I think that solitary confinement is a good sign of what's happening in the prison more generally. It's the extreme side, but you look at the solitary confinement unit, is there anyone there at all? There are some places where the units tend to be empty, long may it continue. I think it gives you a good indication of the prison system. And part of my problem, I like Ida, I think that I try to do two things in my practice. One is to promote abolition of solitary and maybe prisons more generally, and on the other, try and live in the reality that is here and now, which is there are prisons, there is solitary confinement, and I think that what a lot of my colleagues, certainly academics, less practitioners, sometimes the abolitionists tend to do is they don't talk to anyone. They're so pure that they won't talk to prison people, they won't dirty their, and I have a problem with that. I think that we need to be practical, and I think that we need to do work on the ground. Maybe I'm compromised, I don't know, but I feel quite strongly about that.
Hello, my name is Homer Venters. I'm here with Physicians for Human Rights, although up until 2 weeks ago I ran the Correctional Health Service at Rikers Island. And so actually from that experience and the data that you referenced, thank you very much on the analysis of the harms of solitary, two reflections I wanted to ask you to comment on. One is that we find that we had to introduce dual loyalty trainings and assessments for all of our staff that are routine, just like a hospital would train everybody every year on infection control. We find that if you don't constantly look for the impact of dual loyalty and train and support your staff, then it's almost meaningless. These rules we're talking about, what healthcare providers should do, these edicts about they should act in the best interest of patients, it never happens. It won't happen unless you're constantly supporting the staff and scrubbing their daily experience for how dual loyalty impacts. And the other is on this issue of clearance. We had great success with using the initial health interactions when people come into the system that are much more genuine between a provider and a patient, to use that with our electronic medical record to give people labels so that the staff, everybody who comes in, whether they got into trouble or not, would have a label that says you can't ever go into the box. That way, that label is there down the road when there's a problem. So it doesn't mean that we've solved the problem of getting the staff out of the decision making, but the data was collected and conferred to security in a much more clinical setting, not the crucible of something happened and security wants to punish.
Thank you very much for this comment. For those of you who are not familiar with the Danish system, I want to share with you a bit what it's like, the healthcare system. Doctors working in prisons in Denmark are employed not by the Ministry of Health, but by prison health authorities. That's one thing. The second thing is you talk about dual loyalty trainings. Because the doctors are employed by the prison authorities, there's no systematized training of medical doctors working in prisons. meaning, or of any other health staff, meaning that that the healthcare system is very fragmented and that each one does what he feels is best. But often, and I speak from my own experience as a member of the Danish National Preventive Mechanism, often with very little knowledge about the particular healthcare problems that prisoners face while in prison. And also the initial medical examination is, that you also mentioned, is not used on a systematic basis to point out those who might eventually be in trouble in the prison in general, and if put into solitary confinement specifically.
Thank you. Do you have comments? No? Well, yes, sorry. Just to say, I think it's absolutely crucial for prison doctors to be employed by the Ministry of Health. I also find, well, for various reasons, let's not get into the dual loyalty, it's a whole discussion in itself. But one thing that I did find is that doctors should be reminded, I mean, this is such basic ethical rules. They need to be reminded that they are first and utmost responsible, answerable to their patient. And this is a patient. It may be a prisoner, it may be an incredibly dangerous or unpleasant or whatever individual, but it is a patient. So I think we need to kind of keep drumming that on and on and on. I'm quite shocked. I hadn't realized that Denmark, the doctors are still employed by the prison. Something to work on, huh?
Just a short comment. There is a problem that we haven't talked about. That a lot of prisoners feel it's so humiliating to tell about their problems. They are afraid, they think they're getting crazy, and they feel humiliated. So that makes it very difficult also to get to know about a prisoner's health situation, because he would hide it away, because he doesn't want to show that he is not a strong man and he is close to breaking down. So that's a problem that we have to deal with as well.
Yes, there was a question.
And my name is Marte Rua. I'm doing a PhD about solitary confinement in Norway at the Department of Criminology at the University of Oslo. I'm also part of the Scandinavian solitary confinement network together with Ida and Peter there, and I think, I'm just so grateful for this conference, so thank you all. In Norway, the prison doctors are imported from the municipality where the prison is located and not employed by the prison. But I did a study where I interviewed prison doctors about their practices and knowledge of solitary confinement, and I will just warn about the belief in that this kind of systematic way of organizing the prison healthcare system is enough. Because what happened, and what is still the situation in Norway, is that the healthcare system, or the healthcare, the health department, the health authorities, they do not have an interest of prison health care, and the prison doctors are left to themselves, and they're not aware of anything else than what they see, and it's nothing that directs their view or their eyes into the solitary confinement system or to isolated prisoners. Actually, in a way that makes the prison doctors not thinking that prisoners being isolated is anything they should think of, really. So in practice, they don't feel a responsibility for health risks when prisoners are isolated, or of isolated prisoners at all. So I think this is, and also the dual loyalty problem was that in earlier days there was they would have these guidances, from about how to deal with these issues, and there was a continuous reminding there of the dual loyalty. But new guidances were made by the health directorate with people with not such a high level of interest of these problems have now left it out. And so I think it's just this continuous, I mean, and it has to go through other places, and I think maybe when it comes to solitary confinement, it's quite normal to go to the legal parts of the politics in here, but I think it's quite important to go through other ways as well, and particularly with the health authorities who do not really, who have the prisoners in their blind spots, really.
Hi, I'm Annette Storgård. I'm from the University of Aarhus. My questions are small and a little bit technical, so let me be fast. It is about the increased risk of suicide that several of you mentioned. I just wanted to, excuse me if I didn't listen carefully enough, but I wanted to tell us if you, when talking about the increased risk, then refer to studies on custody or to studies on isolation as a whole, both in custody and in prisons, and both as disciplinary measure and as preventive measure while in prison. And the next question is, the risk rates that you told us about, are they describing suicides during the isolation or also in some time after the isolation? And then how long was the follow-up, if there was a follow-up? Thank you.
Can I suggest that the answer maybe Høgh can, because you did a big study, didn't you?
Yeah, so we did a study, it was, and this is just one study, so we took 225,000 jail admissions, so this is a jail pre-trial, and then we looked at those 225,000 admissions, which was 134,000 people. We looked at exposure to solitary confinement as an independent risk factor for self-harm and high lethality self-harm, which included both taking one's life, but also self-harm that could have led to the loss of life. And so there we looked around when we said exposure to solitaire, we included, I think, 72 hours on each end, because we found actually this amazing histogram where the self-harm really peaks in the jail in a pre-trial setting right around the going into, so in the couple days going up to, and then in the first few days there, and then it actually trails off, which is probably different from prisons. And I can pass that citation to you.
Very short, Høgh Hammerlin, Norwegian sociologist, I think he is, criminologist, you asked about the degree of segregation, and he has shown that the stronger the segregation is, the higher the risk for suicide is. Which means that if you are in pre-trial detention isolation, the risk would be higher than when you are serving a sentence in a prison. Is that an answer? Høgh Hammerlin.
Can I just add briefly that the largest big study is Høgh's study, which he described, and I would say generally when it comes to suicides in solitary confinement, we have a lot of research, and some of it is very old, and it's studies from very different settings, from different countries, some pre-trial populations, sentenced prisoners, etc. And typically you cannot, the data will not allow you to say anything directly about the causal factors, but what you can say is that all of this research from these different settings, different types of imprisonment, tells us that there's a disproportionate and very high frequency of suicides in solitary confinement conditions.
Can I just add one thing? You asked about protective isolation. It's a bit ironic, but often when people are held in isolation for their own protection, and we can talk about that also for all day, but it's very difficult to kill yourself because the prison takes away, or tries to take away, your ability to do that. So I mean, it would be interesting to try and find out, but I think it's made more difficult. So my guess would be that people in protective isolation maybe simply are not able to, but they certainly are able, and they do harm themselves pretty seriously with what they can.
It's wonderful with all these questions. I think we have time for maybe one last question before we close the panel.
Hi, thanks again. I just want to pick up, Vicky Canning from the Open University, I just want to pick up on what Martha said and some of the things I think it was Ida said. And that is the objectives and mandates of, for example, healthcare in prisons. But again, I mentioned earlier about corporations and privatisation. In the UK, for example, that is not necessarily the responsibility of health ministries. That has been privatised into, for example, Virgin Care, Richard Branson Virgin Care, and G4S Care. And of course, the mandates of G4S include running the prison, imprisoning people there, other inflictions of harm, as we know globally, and then helping people in prisons. And of course, that comes down to as well the monetary issue of moving people in prison or in solitary confinement. Very short periods of support, very short interactions with healthcare professionals, because the point of them is to make contracts and to make money out of people within prisons. So that is it seems to be another really problematic thing going forward, and that also extends to immigration detention, which in the UK has the informal policy facilitation of short-term solitary confinement for people who are not in for penal reasons, but who are in for immigration-related reasons in detention centres.
Thank you. And apparently there was time for just two more short questions. Yeah.
Thank you. It's Stephanie from the OSC again. I'll make it very short, and it's a very concrete question to Peter Scharff Smith. What you said, going back in history to show us since when we actually already knew the negative impact of isolation. And 3 weeks ago, I think, in the US, where solitary confinement is used on a large scale, we had maybe what I think is one of the strongest dissenting opinions of a Supreme Court judge, Breyer, who again called on the US Supreme Court to look into solitary confinement under the 8th Amendment, which prohibits cruel and unusual punishment. 2 years ago, another Supreme Court judge did the same, and the Supreme Court, as so far, did not enter into this argument, but will hopefully soon. What I'm saying is that both opinions refer to a case 127 years ago, where the US Supreme Court already acknowledged that solitary confinement is cruel, inhuman, degrading punishment. So my question is, how was it even possible that also in Europe, where we copied the US model, as you explained, how was it possible that we even went back and started using solitary confinement to that extent?
Very small question.
Yeah. there's no short answer to that, and I think I'll go back to what I said before. If you look empirically at the history of prisons, it seems that solitary confinement is part of the DNA of prisons, and why is a difficult question to answer, but there seems sociologically, psychologically, I don't know, to be some kind of need for, and I don't mean that there is an actual need, but in the whole system towards maintaining, there are forces, people, agents want to maintain this prison within the prison for a number of various reasons.
Thank you. And the last question.
Yeah, two small questions. On the time factor, because in Denmark now we have seen the recent legislative amendments tripling the first time punishment from 5 days to 15 days. So from a health perspective, how much more damaging is that? And I remember you, Sharon, in your source book, I think you were citing research saying that after 10 days, for sure, it is very damaging. But some remarks on that. And finally, last question, the fact that solitary confinement is used as a punishment, how much more does that add to the negative effects? Yeah, we can take the question in the breaks also, and I am a lawyer, we always ask for firm questions, answers. I'm not sure whether it's possible, but thank you.
The reason I'm slightly kind of because I'm not being evasive, that is I think the situation. Some people will be affected immediately, and some people we know, Nelson Mandela. The Mandela is one obvious example. Some people can withstand solitary confinement for a very long time. I mean, even he said that was the worst thing for him, solitary confinement. But he was in isolation for years. So I think that's why I think that the rule of thumb has to be to avoid using it altogether, because it's such a constellation of factors that you have to work in, the individual's history and past experience and past incarceration experience, and so many different factors that we cannot say with certainty, look, don't worry, 4 days, 5 days is fine, you don't have to worry about it. Some people will absolutely lose it. I mean, we don't know what triggers things in them. So I don't think there is an answer. I really do think that the best way in terms of duration is to avoid it, but there is no doubt, as Ida said, literature is very clear, the longer the duration, the higher the risk. That's obvious. So 15 days, 3 times the risk, it's a very high increase. Is my math okay? 15 days. I think you can answer the second question.
What was the second question? Well, I mean, we have no research showing that because it's a disciplinary measure that effects will be worse, or so it will be speculation. And I guess once again it would depend on the individual cases. We'll have to refer that to the psychologist as an obvious case for arguing that if you feel very, very unfairly treated, then it could be a factor in that process as well. So, but we have no research on that.
Thank you very much. I think we've already passed on.